you through give you a current status update, both in terms of RNAO's involvement in the end-of-life resolution and the physician-assisted death, the decision by the Supreme Court, and also to give you an overview of where both potentially and federally the law is at. On the webinar, you can submit through the chat line questions or comments, and then Josephine will read them off, and then I'll certainly try and provide responses to your questions and comments, and we can further open it up for more dialogue depending on the need. So let me begin by walking you through the resolution. The resolution states that whereas a national discussion is underway regarding end-of-life care, with specific emphasis on dying with dignity, which involves a review of assisted suicide and euthanasia, whereas the final decision on permitting assisted suicide and or euthanasia rests with the public, and as there is support from all three provincial political parties to engage in a discussion regarding end-of-life care. And whereas RNAO is being asked by stakeholders and the media to comment on this issue, therefore be it resolved that RNAO urge the provincial and federal governments to engage in formal public dialogue on end-of-life issues and dying with dignity, including discussions related to assisted suicide and or euthanasia. So let me pause here for just a moment because I want to make sure that people recognize the resolution is not about a position for or against. In fact, that was a decision that was made at the time by the system. The resolution is really about ensuring that the public is able to weigh in on the decision that was being made and the decisions going forward in relation to the framework and regulations that will be built to serve the Supreme Court's decision. Are we okay on the line, Josephine?
I just have some requests from a few participants that they are finding it a bit hard to hear you. Do you mind just speaking up? No?
Sure.
Thank you.
No problem. Okay. And so just to pause here for a moment, in consideration of what the resolution really intended, what the resolution means is that RNAO is that a public dialogue occur. It's not about a for or against position regarding assisted suicide and or euthanasia. So I just wanted to clarify that at that point. The next piece really speaks to principles around the framework to be built and the regulations to support the legalization of physician-assisted death. So the first piece speaks to personal autonomy and justice are fundamental principles. The second is about ensuring timely access to evidence-based palliative care must remain a top priority. And again, just a commentary here that in the cross-jurisdictional review analysis work that was done by RNAO, certainly we have seen that across many countries where law has been implemented for assisted suicide and euthanasia, that it has really shone a light on the need to have a comprehensive, robust program of palliative care. And in fact, many of the countries and other jurisdictions have invested heavily on ensuring that service for palliative care exists in their community. The government must reject calls for involuntary euthanasia, and that is the final key principle that was put forward in the resolution. Therefore, be it further resolved that the following principles be considered when discussing assisted suicide and or euthanasia. First, that assisted suicide and or euthanasia must never be considered within the context of cost savings. This is not a financial construct. Procedural safeguards must be enacted, including restricting assisted suicide and or euthanasia to competent adults with terminal illness. The law, as it has been, as the Supreme Court has made its decision on the law. It only refers to adults. It does not reference children in the law at all. Requiring that requests for assisted suicide and or euthanasia be initiated by the person seeking the services and would be subject to a thorough review process that includes independent confirmation on terminal illness, determination of capacity by a mental health care professional with appeal to the consent and capacity, providing access to all reasonable alternatives, and establishing a waiting period. The key principles are also embedded in the broad strokes of the decision made by the Supreme Court of Canada. So our resolution and the principled framework that we approached in the resolution is very consistent with the decision of the Supreme Court. Or be it further resolved that the following principles be considered when discussing assisted suicide and or euthanasia. The practice of assisted suicide and or voluntary active euthanasia must be restricted to professionals who have sought designated education and training. No health professional or organization should be required to participate in assisted suicide and or voluntary active euthanasia. And a provincial monitoring and reporting system must be developed, including a process for responding to complaints. Each of these components is also contained within the broad scopes of the decision made by the Supreme Court of Canada. In relation to the RNAO resolution, consultation representatives was supported by a large majority vote a resolution from RNAO's Board of Directors at the 2014 Annual General Meeting calling for a formal public dialogue on the end-of-life issues and dying with dignity. So let me pause again here for a moment before I go on to the current context. Josephine, I would ask if there are any questions or comments at this point that you read them out, please.
Sure. We have received 3 questions so far.
Okay.
And I'll be reading it on the line, and for those on the webinar, I'll also be posting them inside the whiteboard so that you can see it on the screen.
Okay, good. Thank you.
First question is, how do we ensure palliative care be available for the 70% of Canadians who cannot currently access this nursing/medical specialty?
How do you ensure palliative care
be available for the 70% of Canadians who cannot currently access this specialty?
So I have a short answer for you. One of the important considerations in putting forward the resolution was certainly that we push the government, based on the Supreme Court's decision, to embed within it the issue of palliative care, knowing what currently exists is a very fragmented system, a system that does not allow for equitable access to palliative care services, a system that does not provide currently people who are in distress based on illnesses or conditions that allow them to ensure that the final decisions based on their life and their health is incorporate all of those measures, supportive measures that palliative care can provide. And so that was one of the key provisions in the resolutions that went forward, and one of the key aspects of advocacy that RNAO is taking on.
Thank you, Vanessa. I just want to take this opportunity to remind everyone to mute your teleconference line so that we have minimal discussion. And if you do not have a mute button on your phone, you can also press *6 as a way to mute. Okay, thank you.
Do you have another question, Joe, that's related to the solution?
Yes. So we have received a few further questions.
Sure.
The next question is, how do we assure safety for the vulnerable, including the elderly, disabled persons, etc.?
Another excellent question. So again, contained and embedded in the resolution is the principles that I spoke to about pause periods, restricting access to assisted suicide and or euthanasia to only competent adults, requiring that the request for assisted suicide and or euthanasia be initiated by the person seeking the service, that there be a review process, that there be an independent confirmation of the illness to which the person is exposed, that there be a determination of capacity by a mental health care professional, also with an additional appeal to the Consent and Capacity Board if necessary, then again providing access to all reasonable alternatives. For example, the question about palliative care, ensuring that palliative care services are available, and also the establishment of a wait period or a pause period of reflection, so that there is at each stage an ability for the person to think about the decision that they've made, to reaffirm their decision, or to gain more information that will help them to come to their final conclusion.
Vanessa, may I read the next question?
Sure.
Okay. How will RNAO protect nurses' right of conscientious objection when moral, ethical, or faith frameworks do not include causing death?
So, again, within the resolution, the issue of conscientious objection has been built. I'm just turning my pages.
Yes, it's going to be similar. Very similar, I think. I want to do it work in a different area.
Sorry. If you look at the piece that talks about the further principles, no health professional or organization should be required to participate in assisted suicide and or voluntary active euthanasia. So a conscious objection has been built both in the resolution and in the Supreme Court of Canada's decision. The issue of conscientious objection has also been embedded.
Thank you, Lisa. Our next question is, at what age is a person considered to be an adult and able to make an informed choice?
Excellent question. This is one of the key questions in the broad strokes plan, in the broad strokes decision of the Supreme Court of Canada that has yet to be defined. Some of the concepts, in fact, many of the concepts, for example, the concept of competency also has not yet been defined. The Ontario government, in its analysis of the Supreme Court of Canada's decision, will have to put forward specific definitions of each of those components that has been, again, in broad strokes decided upon the Supreme Court of Canada. So the Ontario government has yet to reveal the key definitions or the framework in which they are building the regulations for the province of Ontario.
Thank you, Vanessa. Our next question is, has there been any talk about how long the process will take, what the expected wait time looks like for approval?
For approval of which component?
Did not specify.
So I guess I'll respond, and then if I'm not answering your question, please send another question in. Is the question about the entire process from when a person requests physician-assisted death to the end of the process? If that is the question, again, that's part of the government's discussion around the framework and the regulatory pieces. So I don't have an answer for you about how long that process will be. If the question is about how much time do we have before the Supreme Court of Canada's ruling is enacted in the system, that is by February the 6th, 2016. So as of February 6, 2016, unless there is a request from the federal government for an extension on the ruling, then the framework and the regulations will have to be built for organizations to actually implement this in the field. So if I didn't answer your question with either one of those responses, please resend your question with just a little bit more detail.
That's great. Thank you, Vanessa. Our next question, it's a bit of a longer question, so I'll take some time to read it slowly.
Okay.
Is there anything that can be done regarding staffing levels to palliative care units? Often there is pressure to maintain occupancy on these units and to keep staffing levels down. What these units require is more staffing to manage the events which occur, such as quick deterioration of the patient.
Certainly, as I think many people are aware, RNAO is very concerned about the status of palliative care systems and services in Ontario. Certainly, with the implementation, depending on what the implementation looks like, and what I mean is if the government suggests that physician-assisted death can occur in all sectors, so in hospitals, in the community, etc., then there may be even more challenges with this regard, depending on the number of people who make the request for physician-assisted death, which will further compromise volumes and occupancy within organizations and the staffing necessary to support them. I don't have a direct answer for you, but it's a great question in relation to how will this law, depending on where it's implemented in the system, have an impact on staffing to support people both through this process and through their palliative care needs.
Okay, thank you, Vanessa. Our next question, can you elaborate on the finding of capacity, as in who will determine this and what realms will be assessed?
I can't elaborate on that right now because I don't have that information. Again, as you might be aware, there are a number of different methods of determining capacity. It has not yet been defined by the government specifically what that means and what that assessment would look like. And so certainly RNAO, in its consultations with government, will be seeking definitions and approaches to capacity that are robust and that are protective, in particular, of the vulnerable.
Submission is a comment.
Yes.
In saying that euthanasia or assisted suicide will never be considered for cost savings, there are two factors. One, that we do not want the healthcare system to support those measures to save money. Also, we as RHP need to recognize when the costs to the family for unfunded meds, care, etc. are an issue and advocate for funding and care, especially in longer-term palliative care, i.e. for chronic illness like late-stage COPD.
Excellent comment. It's part of the conversation that we need to have to ensure that palliative care services across the spectrum are robust and that they meet the needs of our population, whether it be a staffing concern, whether it be access to medications, whether it be access to community care services, no matter what it is an important component of the spectrum of palliative care and services that we provide. So excellent comment. Thank you.
Okay. Let me the next question for you. If a client has been diagnosed with Alzheimer's, will they be able to give directives for future demise should their wishes be to have assisted suicide when they decline to a certain point?
My understanding, and again, I'm a lawyer, but my understanding to date is that the Supreme Court of Canada ruling is based on people being competent adults. If the person was not competent at the point at which they are requesting physician-assisted suicide, then would not be allowed. There's no mechanism right now, based on the Supreme Court's ruling, that allows for somebody in advance to say, I am faced with these particular circumstances, I would like physician-assisted death. To date, that is the understanding that I have based on the Supreme Court of Canada's ruling.
Great. I have a question from another participant. When did the right to die with dignity become a privilege versus an expectation?
When the right to die
with dignity a privilege versus an expectation?
I would suggest that regardless of circumstances, everyone has the right to die with dignity. There are some people who may find it undignified to live in a particular fashion where they feel they are experiencing intolerable suffering. And in those cases, people might feel that they are prohibited from having a dignified death. So I think that's probably the most that I could say on that matter. Again, this is very personal, decision that people make. The decision made by the Supreme Court of Canada is based on the legal aspects that are contained within a charter, and it doesn't go beyond that.
Okay, thank you, Vanessa. Just another reminder, I believe someone on the line needs to mute their phone. So if you could just take a minute to either use the mute button on your phone or you can press *6. Okay. Our next question. What type of ethical and theoretical frameworks are suggested for guidelines in setting standards, teaching nurses and the public?
The educational components, those not been articulated yet to my knowledge. Ethical and theoretical frameworks, the specifics around that education regarding this support decision, to knowledge that has not yet been articulated, but it's a good question.
Okay.
Other questions, or should I move on to the current context?
We have no further questions at this time. If you would like to proceed with the slides.
Okay, so I'm going to proceed with the slides, so we'll talk a little bit about the current context. And as I've mentioned a couple of times, the Supreme Court of Canada issued the decision that current prohibitions on physician-assisted suicide are unconstitutional. And they gave government until February 2016, and my understanding is that the firm date is February the 6th, 2016, to make revisions to the law. It's anticipated that the federal government will seek a 6-month extension. To date, as of today, my understanding is the federal government has not sought an extension. The extension, if the federal government was seeking an extension, they would have to appeal to the Supreme Court of Canada for that extension. The purpose of the extension is to further allow provinces and territories across the country to develop their frameworks and to develop the regulations under the law. The federal government has established a 3-person panel to engage Canadians and key stakeholders to inform the government's response to the court's decision, and that panel has undertaken some work to date. There has been a survey that has been put out to the public, and there have been conversations around that table. I do not have the details, but there have been conversations around that table regarding some of the principles and regulations that need to be considered by provinces and territories across the country. And then the provincial territorial governments are moving forward with a non-person pan-Canadian advisory committee to provide advice on policies, practices, and safeguards. Again, they have not released their report on the consultation that has happened across that table. Quebec passed Bill 52 and has already enacted its law in relation to assisted death. RNAO's involvement, our activities to date, we held webinars in October of 2014, in February of 2015, and we had 600 attendees across both those webinars. Held a closing keynote panel at the RNAO AGM End of Life Care Voices and Perspectives. The panel included representation from Palliative Care Nurses Interest Group, the Parish Nursing Interest Group. We had an international guest, where the law has been enacted for several years, and had a family member of a loved one who had passed away and did not have access to assisted death, and the family member told their story and their journey across their illness. And the 560 attendees at this event included members of the public. The public was invited to weigh in and ask questions and provide comments and concerns. The RNAO has submitted to the federal government panel the concepts that are outlined within the RNAO resolution, high-level critical issues around some of the principles and what the framework may need to contain. RNAO has been engaged with the Law Commission of Ontario's advisory group to get a better understanding of the legal aspects surrounding physician-assisted death. Also have been involved with Health Law in Canada conference, again as part of a panel on the advisory group on medical aid in dying. And we had a feature in the Registered Journal feature, which the link is included in your presentation. The federal election platform, we called for a national palliative care strategy to provide universal access to quality palliative care and a principled regulatory framework to implement assisted dying. We participated in the Ministry of Health and Long-Term Care palliative care consultation that was initiated by Parliamentary Assistant John Fraser. And we have had some discussions with the Ministry of Health and Long-Term Care and other partners regarding the framework and the regulations in the context of implementing the law as set out by the Supreme Court of Canada. In terms of nurses' voices, the voice of registered nurses and nurse practitioners is a reliable and expected source of information for the public. The public wants to hear from us, as they do on many, many issues that concern their health and well-being. Nurse students as well need to have their perspectives known, and they must be heard. The resolution speaks to end number 3, which is speaking out on emerging issues that impact on nurses and the nursing profession, health and health care, and end 4, which is around influencing healthy public policy. Next steps for RNAO is to continue to engage with members, politicians, and the media to advance the formal public dialogue on end-of-life issues, including assisted death. Doris is fantastic at using Twitter to ensure that she provides regular updates as they occur. Please know that you can always go to RNAO's website, www.rnao.ca, to check for the latest information and updates surrounding this issue. So, again, I want to be able to open up a line to other questions that I may be able to answer, to comments, or to other suggestions or recommendations to support our ability to ensure that across our engagement with government and with others, that we can continue to influence a principled framework and the necessary regulations that protect the public and protect nursing.
So if Vanessa, you're ready, I can start to read out the questions that we've been receiving.
Yep.
Okay. Quebec's physicians and palliative care units and institutions have refused to participate in euthanasia and physician-assisted suicide. Punitive action against them is being considered by Quebec's Assembly. How do we avoid this?
Well, two things. The Supreme Court of Canada's broad strokes ruling allows for conscientious objection in the rule, and the framework that and the regulations being put forward by RNAO and by the Medical Association allow for conscientious objection. And so, again, the direction based on the Supreme Court of Canada and based on some of the key stakeholders in the construction of the framework and regulations all have conscientious objection embedded into it.
Okay. The next question. Thank you, Vanessa. It is very concerning that an individual who knows they are descending into the depths of dementia or they have a degenerative disease that will eventually not allow them to make choice. Is this being addressed at all?
So the topic of this conversation, my understanding, has been raised as an issue of concern. The focus of this particular concern, I don't know if there has been. I think so. Let me step back a minute. I think one of the issues is that the definition of competency is one piece of this. The definition of how capacity will be determined is the second piece of this. ruling at this point does not enable the law to be applied in any other circumstances at this point. But my understanding, based on some of the conversations in the legal community, is that there may be an opportunity to broaden the language and to be able to have some consideration for just what you're talking about, people who have Alzheimer's or other conditions where they would want to establish their own protocols for when they get to a place where that they're deciding where they feel their quality of life is eroded, and they would like to access this law. But there isn't anything definitive about that right now. But the concern has certainly been raised. The issue has been raised.
Thank you, Vanessa. The person on the line who still has their line unmuted could just up their phone, please. Use *6. I'll read the next question for you, Vanessa.
Okay.
Do others worry about the future expansion of euthanasia? At age 84, I am fearful of going into hospital for needed abdominal surgery in 2016. What if I don't heal on schedule and become a bed blocker? Is my life really worth the money in a cash-strapped healthcare system? P.S. Bravo, Vanessa, for the manner in which you're handling this webinar.
Well, thank you very much. I appreciate that. Thank you.
In response to one of the previous questions, someone else on that question by asking, what can we do to raise the important question about descending dementia?
Well, this is the first thing that you can do. I completely appreciate that there isn't a specific table to direct it at now. RNO is certainly engaged in all of the right tables. I think that if there are, and I anticipate that there may be other opportunities publicly or through the media, through other symposiums or any other dialogue event, that this issue be raised. Make your voices heard. All of these issues need to be considered. This is a very important law that is being established, and underneath it, the regulations and the framework really needs to be consistent with what the public believes it needs, and we need to advocate for that. So that would be my recommendation at this point, is engage as much as possible where public dialogues are occurring. And again, thank you for participating tonight, because all of the information that you provide to us through your questions, through concerns that you raise, through the comments that you make, we have a tally of all of those, of all the previous 600 people that participated, and all of you that are participating tonight. And all of that gets translated into an analysis that informs the work that we're doing with ministry and with other stakeholders. So it's very, very important that whatever issues, questions you have, please raise them, because it only helps us to further inform the framework and the regulation.
Thank you, Vanessa. Our next submission is a comment.
Yes.
I highly recommend people read Quebec's Bill 52 and related materials. It addresses advanced medical directives.
Excellent suggestion. Thank you. I ask, is that available online?
It is.
Okay, thank you so much. Excellent suggestion. I have not had the opportunity to read fully. I know the concepts of the Bill 52 and have seen some of the protocols, but I haven't read the entire bill, so thank you.
Okay, our next question. Physician-assisted euthanasia be part of advanced care directives for clients who are early stage of Alzheimer's and competent to make his or her own decision?
Don't believe at this point that that is part of the Supreme Court's ruling.
I'm looking at the lady spouse and are you negotiable?
Question. Let me just make it small. Does the RNAO have concerns regarding the mental health of professionals who participate in euthanasia or physician-assisted death? Such issues as post-traumatic stress disorder and guilt are reported from jurisdictions where the law allows this.
Anyone, again, a key principle here is conscientious objection. The thing about this ruling is it's going to make all of us reflect upon our practice, and reflect upon our ethics, and reflect upon the nature of patient-centered. And I think that that's a really good thing. You will all recognize that already contained within our guidelines, within our guidelines and standards for practice, that any ethical dilemma that we're experiencing, and it could be about any issue, it could be about other challenging situations like abortion, or it could be about a situation where a person declines therapeutic intervention. It could be about any of those issues where we have to reflect upon, ourselves and can we manage in that situation. And in those cases, we know based on our ethics and based on our college guidelines that we can step away from those situations. It's a conscientious objection. This is another challenging way that's going to require us to really reflect on our practice and what we can manage as a professional and what we can manage as a person. Because at the end of the day, we come to work as human beings, as people, and those sorts of considerations we'll need to really think about. If we do that and we do that well, then where there is engagement by healthcare professionals in physician-assisted death, I think there will still need to be supports because this will be a brand new and very spiritually, emotionally charged kind of practice. And so I still think that there will need to be support in place, but I think the first step is for us to really reflect on, how and if we will engage in this new practice, given this new.
Thank you, Vanessa. I'm just going to try, sorry, I had been to mute everyone's lines. I'm going to try to feature where I do that again. So if you just bear with me for a moment.
Sure.
It has been muted.
Vanessa?
Yeah.
Perfect. Okay, that worked. Sorry about this whole time of the noise. Let me read out the next question for you. Mm-hmm. What does assisted suicide as opposed to euthanasia look or sound like?
Okay, so again, assisted suicide is where a physician may provide to a person who is deemed competent to make the decision that they want assisted suicide. The physician may provide them with the means to so themselves. So the basic premise is that the individual would administer their own medication to their life. And the physician-assisted euthanasia would be where the physician actually administers the dose of medication.
Thank you, Vanna. Our next question. For those living in rural communities, would there be access to the physician-assisted suicide, and will there be services in place that will allow them the access, for example, travel grants?
Yeah, excellent question. And I must tell you, in most recent conversations that I have had with stakeholder groups, that this has emerged as a critical issue because the requirements necessary for implementing the Supreme Court decision is an assurance of access to all. In rural communities, I believe that there will be challenges for people who may not have access because of services and and all of those factors that enable people to have appropriate access. So this is a key consideration in the development of the framework and in the development of resources and supports for rural and remote areas. And it has been part of the discussion that I know RNAO has engaged on, and I have engaged on in the context of building the framework for implementation in Ontario. Excellent question.
Mm-hmm. Our next question is, with conscientious objection, can nurses be punished, perhaps subtly, by their institutions for not participating? So based on the law, based on the pure law, no one should be punished for a conscientious objection. I suppose that, I could not say to you 100% this wouldn't happen within an organization. It would certainly be dependent upon the culture of the organization and I'm sure a variety of variables. But intent of setting forth in the perennial resolution what's in the Supreme Court decision and in the medical associations principle around conscientious objection, that is what we're absolutely trying to avoid, that anyone is punished for their conscientious objection. Is there a possibility that might happen? Sure. I mean, trying to close the loop and making sure that doesn't happen is the aim, but there's always a possibility that might happen. Mm-hmm. The next comment is, it was too late for the Alzheimer's patient to make a competent decision when the time comes, if not allowed to be included in advance directives. Should be part of the discussion on policies. I
agree with you. And it is forming, it's not only the Alzheimer's patients, but it's the whole issue of being able to enact the law through an advance directive. Right now, my understanding is that the Supreme Court decision does not provide for that. So it is part of the conversation, but there is a bigger context piece around this. It's not just specific to Alzheimer's patients.
Mm-hmm. Our question is, does RNAO believe that physicians and nurses will enjoy the same level of trust if they participate?
the same level of trust in, could clarify that question? Not sure what the question is asking.
Okay. And who submitted it could just provide clarification in the chat box. I can
Then
read
we'll
it.
go on to the next question.
Sure.
And just clarify what you're asking, and I'll be happy to try and respond to it.
Okay.
The next question, Joe.
Sure. How can we keep pressure on our teaching institutions to include palliative care at an undergrad level, also education of those in current practice settings?
Excellent question. I think it's such an important component, and there's so little of that education and teaching that currently exists. And again, I would use the resources available to you through has been through CUPIN, through sort of the both the provincial bodies and continue with the conversation across groups that you're involved in through your academic institutions. No, it's always a challenge because the nursing curriculum is so jam-packed. But with the significance of this law, it may be that the timing is right to really start to push for an enhanced curriculum around the whole palliative care education piece and training piece and clinical placement piece. So great and great thought.
In response to one of the earlier questions, someone submitted the comment that for men to be punished for not participating would be so non-productive because PTSD would cost more to the health system than just leaving people to live by their consciences.
Yeah, absolutely great point. I'm certainly, taking a positive view to this, that organizations would recognize the need and adhere to and support conscientious objection from a professional staff person. And certainly it would be very, very discouraging for any organization to be punitive in any shape or form to someone who has issued a conscientious objection. And it would be so detrimental. It would be detrimental to the system, to the organization. And so let's continue to ensure that those pieces which are already, as I said, embedded in the Supreme Court decision, that they are, firmly embedded in the framework as well. Just to that we close off that possibility.
Mm-hmm. Earlier submitter of the question that required clarification just resubmitted.
Yes.
They now worded the question as, will persons trust doctors and nurses who participated in assisted death at the same level they now enjoy?
That's a good question, and I think it's a question that I only have a personal reflection on. As professionals, I think that one of the things that I would say about trust is that the public, as you know, a nurse is more than any other profession. If you look for years upon years to the to the different survey polls, the Ipsos Reid, etc., top profession that when people ask who do they trust, it's nurses. Usually the bottom is politicians, by the way. And so I know if that will change. But what I do know is that the public has asked nurses to weigh in on this dialogue. The public has asked for nurses to be involved in the discussion, to support the public's ability to be involved in the discussion. So it is the public who is asking for, and it was the public that demanded that this particular law be addressed. So, from that vantage point, that's my vantage point, and I think will remain as a trusted profession simply by responding to what the public has asked us to do and how they have asked us to advocate on their behalf to ensure that their voices are heard. So that would be my perspective, and I think time will tell. If there are perspectives, please feel free to share them.
Our next question is, could the palliative care nurses interest group redefine terminal so that persons months away from death do not fear palliative / hospice care?
And read that again.
Sure.
Sorry, Josephine.
Yeah, of course. Could the palliative care nurses interest group redefine terminal so that persons who are months away from death do not fear palliative or hospice care?
Redefine terminal for the system, is that, I'm just not clear of what the question, like redefine terminal in the context of the systems definition or definitions in the literature. I'm not quite sure. So maybe if just help me out, whoever asked that question, if you could just clarify that, then I'll be happy to try and answer it.
Okay. In the meantime, I'll just move on to the next question.
Yes, thank you.
Could we look at the idea of death clinics and trained euthananologists instead of medical / nursing professionals? This is being done in the Netherlands.
Again, the law is specific to physicians. So the law, as was put forward by the Supreme Court, does not allow for anyone other than physicians to provide assisted death. I don't know if in the future there might be opportunity to examine, alternate providers other than physicians, but at the present time, it is physicians only.
We haven't received clarification from the previous question, so
we'll keep going until we receive it, and then we'll revisit that.
Sure. The next submission is a comment.
Yes.
The whole issue is so reminiscent of days past. Abortion and a woman's right of choice were in question and debated. We nurses managed that crisis, and I'm confident that as a collective, an even more powerful group today, we will also come to an agreement that respects a person's overall right to choose while protecting those who really don't want to participate in the act itself.
Wow, that was an excellent comment. Thank you. I must tell you that I absolutely agree with you. We're knowledge professionals. And combined with that knowledge, we have the special art of therapeutic intervention. We have sound scientific knowledge of how to communicate with people, how to support people, families and communities. And I think that we have strong insight into what meeting people's needs is about and what patient-centered care is about. And I absolutely agree with that comment, and thank you. That was quite prolific. Thank you very much for that comment.
Okay. Someone is responding to the earlier question about trust.
Oh, yes. Okay. Thank you.
Comment is, I do not think the trust factor would be affected because the drugs to be used in this procedure would not be simply lying there to be used ad lib.
Yes, if you're talking about just in terms of a person thinking that they are going to be administering something that might potentially be lethal, I don't think so either. I mean, there's a lot of safeguards to medication administration. And the other part of it is that I think we need to give our public a lot of credit for being much more engaged in their own care, much savvy in terms of asking questions. Their knowledge level of the system, I think, has increased exponentially over the past 10 years, and expectations of us and their engagement in their care and safeguarding is at an all-time high level at this point. So I would agree with that last comment.
And the earlier submitter of the question of defining terminal.
Yes, thank you.
Yeah, they're finding that redefine terminal as end of life when all systems fail and death is imminent. So many avoid palliative care when it means only terminal care.
Okay. So I guess that's one of the issues that might need to be discussed when there's more conversation about how we build a palliative care system and services that meet the needs of people. And if that is a factor that is contributing to people's sense of, not needing to enter into palliative care or otherwise, then it needs to be considered. So maybe what I'll do is certainly take note of the issue of definition of terminal and to look at that from, to look at that definition and ensure that it is appropriate in the context of physician-assisted deaths and in our desire to enhance the kind of palliative care services that are being provided across Ontario. Is notable from the person who's submitted the question or the comment?
They haven't responded yet, but
okay.
They can feel free to submit that and I'll read it.
Sure.
Okay. Someone else has a question that's in relation to the trust issue.
Yeah.
Will participation in assisted death be quote-unquote anonymous, i.e., will names be published for the public to see? Will coworkers be punished for discussing the involvement of anyone in assisted death?
So, in terms of published, I'm sorry, read it again, Joseph.
Sure. Will participation in assisted suicide be anonymous? Will names be published for the public to see? Will coworkers be published for discussing the involvement of anyone in assisted death?
So again, in terms of, being published, in terms of being anonymous, I don't know that there would be any consideration. I've not heard any consideration publishing anybody's names for their involvement in physician-assisted death. I don't know what the intention around that would be, or I'm not sure of the impetus of the question. So men who were asked the question, if they could elaborate on what we're trying to get at there. In terms of being punished for being involved, I think I've discussed that before in the context of conscientious objection. But certain how to answer the question about the names or anonymous. I mean, if you're talking about how, for example, the College of Nurses of Ontario publish your name as a registered nurse, that's a public protection initiative, and the details surrounding your particular practice or involvement is not published. I'm just not sure of the impetus of the question for the published and the anonymous. The anonymous, I'm not sure. I'm not how you could be anonymous if you were executing the practice of physician-assisted death within like a public hospital, or even if you were, depending on where it's allowed by the law, where this will happen. I don't know how you could be anonymous. I mean, I'm not sure about that.
Mm-hmm. Okay. Our next comment is widespread public involvement in this process is so important. The public has been asking for some progress on this issue for as many years as I've been a nurse, 39 years.
Absolutely. Thank you for that comment. So true. Yep. The public wants to be involved, and thus far, there has been some really significant public involvement. The surveys that have been put out across the country, have been fantastic. I've had the opportunity to weigh in on some of them, and I've seen them, some of the results, and the public have spoken, I guess is what I want to say, and I think that's fantastic.
Some would like to know, what do you think of the Quebec situation?
In what regard?
Not provided any further specifications. So
okay, if the person that asked the question could please be specific.
Okay. Moving on to the next question then. How families be integrated into individual care plans that include assisted suicide and euthanasia?
Oh, that's a great question. And I think, as with any other therapeutic plan, that there needs to be family involvement based on the desires of the patient, of course. But that's going to have to be integrated into the plan of care within physician-assisted death as much as possible. We need to meet the needs and the desires of the patient in the context of where, when, and how they want their family involved. And so, again, those on-the-ground implementation details, most of those will need to be worked out, I think, organization by organization. But certainly the key concepts of patient-centered care, patient experience, all of those things will need to be integrated into that plan of care.
Okay, thank you, Vanessa. Our next question. Physicians in Quebec have been instructed not to chart assisted death. They must only put the underlying pathology on the death certificate. What do you think of this idea?
What do I think of that idea? I guess I don't really have a comment on it. I don't know. I would need to understand what rationale was. It might be based on the law. It might be based on the issuance of death certificates. I would just need to understand more of the context behind it in order to provide an informed comment on it. Sorry.
To note to everyone that there's 15 minutes left in this scheduled webinar. And no further questions at this point.
Okay. Josephine said we have 15 minutes left. And please, if you have a question or a concern or, another issue that you want to bring forward around the end-of-life resolution, around physician-assisted death, please feel free to do so. We're happy to hear all perspectives. We need to hear all perspectives. Might not be able to answer all of your questions, but I'm certainly happy to hear them because, again, they have to inform discussions that we're having around the framework and around the regulations. So feel free to make your comments and to provide your, if you have any suggestions, please feel free to do that. If there are questions, we're happy to try and answer them.
So we've received a few more.
Okay.
Regarding anonymous participation,
Yes.
I understand participation will be documented and confidentiality is supposed to be adhered to.
Right.
However, we all know coworkers talk among themselves and not always in a controlled environment.
Yeah.
How will participants' involvement be kept confidential from coworkers not involved in a case of physician-assisted death?
I think you have to put it in the context of any other practice that you're involved in. So, the rules of confidentiality, the rules of maintaining people's privacy, the rules of non-disclosure of information about patients and their therapeutic interventions, they will all apply to this practice as well. So know that I can give you an answer beyond that. Just as much as you're obliged not to have conversations about a intervention that involves a therapeutic abortion. It's not within, if it's not within your realm of care, if you're not involved directly in the care, all of those same rules of confidentiality and privacy and, professional decorum still all apply, and the expectations certainly will be that they absolutely apply in this instance as well.
Mm-hmm. Someone else asks in relation to this, how can the participation be anonymous when there is a circle of care and multiple people need to know of the plan of care?
Exactly, and that's what I was trying to get at.
Mm-hmm.
I mean, it will be important to ensure, based on the therapeutic care plan, that all of the necessary resources and supports are put in place for the family and for the patient. So it may have a number of care providers, and you would not want to isolate these patients from the entire circle of care. It would, in my opinion, be quite inappropriate to do that.
Okay. Next submission. Can nurses opt out of participating in assisted death in some cases and participate in other cases if they are in agreement with the doctor's order to assist death? This would be very hard to manage and would be a difficult decision to be made on an individual patient basis by the nurse participating.
So I would go back to, I guess, our standards of practice and ethical considerations. I haven't put a lot of thought around opting in and opting out. I'm trying to think of a circumstance where, a conscientious objection would be not to one particular physician-assisted death, and maybe not in another. I have a hard time reconciling that in my mind. If you have a conscientious objection, I guess I would think that it would apply in all circumstances. But I would need to give more around that. In terms of how that aligns with the our standards of practice and ethical considerations, I think there's no black or white answer to this, but the person would have to really, we will have to really think about what it means to deliver patient-centered care and what it means, this whole issue means ethically to us, and if our ethics are going to, our own personal beliefs are going to interfere with our ability to deliver the best possible care to our patients, then we're required to step aside. So I think sort of at the root of what we're all going to need to do based on this new law.
Thank you, Vanessa. Our next question. Will NAO be lobbying CAUSIN, which is the Canadian Association of Schools of Nursing, to incorporating palliative care in nursing school curriculum? We need to educate nurses. It's rated as nurses need education to be able to provide safe, competent care and start conversations about goals of care earlier in disease processes.
So it's a good question. I don't have at this point. Our NAO is certainly looking at all of the components of a comprehensive palliative care program and service for the system. I will certainly put that forward as one of the considerations, which will ensuring that there is appropriate educational supports for nurses to be able to deliver sound palliative care. So for raising that.
Okay. Someone submitted the comment that I am thinking any MD who decides to be part of the physician-assisted dying group cannot be a secret. People will know just as much as people learn about good or bad MDs.
I thank you for the comment.
I have 5 minutes left, so
okay.
I don't have any more questions or comments at this point, but if anyone would like to, those, please feel free.
Yep, this is, we're getting to the end of our teleconference. We have 5 minutes left. So far, I must comment that questions and the issues that you have raised have been phenomenal. Lots and lots of great thinking going on out there for all of you. So it is very, very much appreciated. And we have a documented account of all of this, and all of it is put forward for consideration, as I said, as we're working with the government and other key stakeholders in our deliberations around the framework and the regulations. So, I mean, it's just been phenomenal, the engagement of, this session of the perennial end-of-life resolution virtual dialogue. So I just want to thank you so much. It's been fantastic.
Someone would like to comment that they'd like to say thank you. You have done an amazing job of answering and commenting.
Oh, thank you. Thank you very much. I appreciate that. It's kind of different kind of, I wish I was standing there in front of all of you. It's a little bit difficult when we're doing it through this kind of venue, but it certainly allows us the opportunity to have the conversation, and for as many people as want to be involved in the conversation. So thank you for that comment. It's very kind of you. Appreciate that.
People are wondering whether they will have received a copy of the PowerPoint.
Absolutely. Josephine, you can give them a copy, right? It's on the website?
Not currently on the website, but I could have it listed along with this webinar as an archived webinar.
Yes, please. That'd be great. Yeah, people want to be able to reference it. And if people have other questions, then they can write them into us as well, right?
For sure.
Okay. Josephine. Have a couple of minutes left, so if there's any other questions or comments now, because there's only a couple of minutes left. But I hear from you. 1 minute yet, Josephine?
Still 3 minutes.
3 minutes. Okay.
Yep. And someone says, I think there has to be more effort put forward to educate the nursing profession that there is a difference between palliative care and terminal end-of-life care.
Excellent point. I agree with you. Thank you for that. I think there's, my opinion is that there's educational needs about, in fact, what palliative care is. I think most people, when they think of palliative care, do go to the terminal stage, but palliative care can be provided across a lifetime, depending on the person's circumstances. So, excellent point.
Another participant asks, will there be another webinar after the February 6th regulations are released?
Jane, have we scheduled them yet?
There will be further sessions, I understand, from Dr. Grinsman, our CEO. And for sure, we could also take into account the scheduling of the release. Yeah,
I think that's a really important point, and I really do think that we should have webinars after the ministry has put out its final framework and its regulation, because I think it's going to be helpful for all of our members. So for raising that, whoever raised that, and we've got that noted. Certainly watch the RNAO website and our In the Loop communications, because we'll continue to update you as this matter evolves, and try and bring you as quickly as possible the most updated information.
Vanessa just said we're our 1 minute mark, and I don't have any further.
Okay. All right. Well, I want to thank everybody again. This has been phenomenal input from all of you. Truly, truly appreciate it. Have a wonderful evening, and thank you for engaging with us. Great.
Vanessa.
Okay, Josephine, I want to thank you too so much for all assistance.
You're welcome. Good night.
Much appreciated. Good night.
Bye.